Welcome to Neurology, Disease Deep Dive. In this series, Dr. Derek Robertson, Director of the Multiple Sclerosis Division at the University of Southern Florida, and from the New York University Grossman School of Medicine Comprehensive MS Care Center, discusses multiple aspects of NMOSD. Dr. Robertson is talking with us today on behalf of Horizon Therapeutics, which is compensating him for his services and is sponsoring this podcast. In this episode, Dr. Robertson presents the importance and tools for monitoring NMOSD and signs, symptoms, and evaluation of disease activity.
Welcome to our second episode in this series. I'm Wendy Terry, publisher of Practical Neurology, and I'm here today with Dr. Derek Robertson from Florida, and we're going to continue our conversation on NMOSD. So, Dr. Robertson, can we just go back and do a brief review of what we talked about with mild and moderate attacks in the last episode, just so we can kind of set a framework for this episode?
Absolutely. And hello, Wendy. Again, I'm happy to kind of pick back up on the conversation and build upon the first episode. So to answer your question, so attacks of NMOSD, I think correctly should be taught, and this is what I teach our medical students and our docs in training here at our university, is to be fearful of the diagnosis. And I think that's on purpose because at least the approach that we take is that we want to have a heightened senses awareness for this specific disease, because not all, but a decent percent of patients' attacks can be so severe that they can become functionally blind from an NMOSD attack, or functionally quadriparetic after a bad spinal cord attack or a transverse myelitis attack. Having said that, I think using that framework to say, be worried, understand what could happen, leaves room for nuance, and that there absolutely are patients that have NMOSD that can have mild or moderate attacks, and what that would look like. Mild cases of optic neuritis can happen with NMOSD. So they would have blurry vision, maybe responsive to acute treatment with, say, IV steroid use, sometimes plasmapheresis. It can help kind of take a case that was maybe going to be moderate or severe, and you can blunt the effects with treatment. Similarly, moderate-based attacks could be things like area post-streamus syndrome, like we mentioned on the last episode. Those sometimes can even be self-limited. When you take a good medical history on an NMOSD patient, sometimes they'll report, yeah, years ago, I did have this weird bout where I had persistent nausea, vomiting, and maybe even hiccups. It lasted for a few weeks, and then it kind of got better on its own. I maybe saw my primary care provider. I maybe went to an ER, and they couldn't quite figure it out, but thankfully it just got better on its own. That very well could have been area post-streamus syndrome. So that sometimes can fall into the mild to moderate category and can be perhaps self-limiting.
Thank you for that review. And then likewise, we also talked about the role of MRI in diagnosing NMOSD. Do you mind just doing a brief review on that? Because then we're going to take that conversation just a little bit further.
Sure. So MRI is absolutely crucial for accurate diagnosis of central nervous system mediated or autoimmune mediated disease. With a focus on NMOSD, the kind of things we would be looking for if a patient presented with optic neuritis, often with NMOSD, it's going to be bilateral optic neuritis. If you did an MRI of the brain, you would want to do dedicated thin slices through the orbits. And what you would often see on post-contrast imaging is enhancement of the posterior portions of the optic nerves, again, often bilateral and simultaneous, and with a decent amount of patients also having involvement of the optic chiasm. So that would be one scenario where neuroimaging could be helpful to identify NMOSD. The area post-streamus syndrome, we mentioned that. Again, it's not incredibly common presentation, but it can happen with this disease. It's one of the defining features of those core 6 clinical characteristics. And the area post-streamus is in the posterior portion of the medulla in the brainstem, the lower portion of the brainstem. And so if you see a T2 hyperintensity or contrast enhancement in that part of the brain in the right clinical context, it could be nearly diagnostic by itself for NMOSD. And then lastly, into the spinal cord, since Transverse myelitis is the most common clinical attack that NMOSD patients can present with. Knowing what that looks like on imaging is really helpful. It's often LETM, or longitudinally extensive transverse myelitis, which means there would be a minimum, often more, of 3 segments, whether it's cervical or thoracic, of involvement of the contiguously of the spinal cord. And it's very often in the middle of the spinal cord, around the central canal. There's lots of astrocytes, as we kind of visited in our first episode and revisit now. And you can get this really expansile central spinal cord lesion that extends up and down, a minimum of 3 segments. And that's the typical type of neuroimaging finding that we would see with somebody that has NMOSD.
Great. And now tell me, what is the role with MRI in monitoring those patients? How often are you using it? What are you looking for?
Unlike other cousin diseases, for lack of a better term, and we'll pick on MS for a second, multiple sclerosis, we do have kind of defined, this is still relatively recent, but defined kind of MRI guidance for utilization, both around timing on diagnosis, as well as, probably more importantly, how to utilize MRI in the ongoing monitoring, whether it's treatment response or prognosticating to some degree for MS patients. We don't have as clear of guidance yet, anyway, for NMOSD. So I could just tell you what we do in our practice. And there's not defined clinical consensus here, but I would say there's some decent uniformity in how we practice here at our center and others, is that MRI is crucial to kind of arriving at a clinical, accurate clinical diagnosis for somebody that has NMOSD. So at the time of diagnosis, and I think there's at least decent consensus to re-baseline somebody, usually about 6 months after you start them on a disease-modifying therapy. And we thankfully have 3 FDA-approved treatments for seropositive NMOSD patients. So if you accurately diagnose somebody, start them on one of those therapies, and then you monitor them over time, capturing a 6-month MRI after start of treatment is incredibly helpful, because then that would be the MRI that you would want to see be their person's baseline moving forward. Where it gets more gray is beyond that. After 6 months, you've established a new baseline, your patient hopefully is doing well. The utility of MRI beyond that is up for debate. I know at our center, we're a little bit more reactive with the MRI, meaning that we don't have regimented, every patient gets an MRI for the first 2 or 3 years. There's some data that suggests patients can have silent MRI activity. And so if a patient has a higher inflammatory disease burden before you get them controlled on treatment, that might be somebody that we bend that to and actually do some type of regular MRI monitoring for a couple of years. But at least generally speaking, in our practice, at the time of diagnosis, rebaselining after 6 months of starting on a new treatment are kind of the standard approaches, and then only as needed based on, say, new symptoms later on.
And what are your standard practices, or what's your standard paradigm for monitoring patients outside of the MRI?
Yes, so we really use, and I think this is at least driven in part from again, those 6 core clinical characteristics that we talked about in the first episode. Those are often incredibly symptomatic. If patients with the 3 most common being optic neuritis, transverse myelitis, and then a distant third, the area postrema syndrome, these are often very symptomatic to the patient. If you have somebody stable on a disease-modifying therapy, they're often stable on the disease-modifying therapy. And if they become unstable, they're very likely to have clinical symptomatology to tell you that. And so periodic examination in the clinic. So we usually see our patients on a 3 to 4 month cadence. These are patients we keep a little closer eye on than, say, kind of a standard MS patient, where we might see once or twice a year at most. We tend to see this type of patient in our neuroimmunology practice a little more frequently. That's our yardstick on how they're doing. So if their neurologic exam remains the same, if they have no new symptoms, visit to visit, that's a patient that likely is very stable, and that's what we use to monitor them by and large.
At the end of episode 1, we talked about biomarkers and where they're at in, the progression of using those in neurology for various disorders. What currently do the biomarkers play in the role of monitoring patients, if any?
It's a tricky question for NMOSD. The best biomarker we have in NMOSD, like we talked about in the first episode, is the actual diagnostic biomarker. So the aquaporin 4 antibody test is incredibly specific for the disease. What it unfortunately is not is a good treatment response biomarker. So what that means is that it doesn't seem to correlate great, that if you followed that lab over time and say the level decreased, that it doesn't seem to correlate with, as it decreases or maybe even extinguishes, that it's indicating the person is stable or in permanent remission or anything like that. That was the hope with the test, and it doesn't seem like in kind of some published data in the medical literature that it supports that. We do not use it that way in clinical practice. There are a few others that are showing promise as attached to some of the pharmacologic therapy trials for NMOSD, things like we talked about in the first episodes, GFAP, so glial fibrillary astrocytic protein. That's at least a promising biomarker that sheds in the spinal fluid as a result of probably of attack of the disease. There's destruction of the astrocyte. That is a byproduct that can show up in the spinal fluid. There's at least some promise with that. If would be a way for it to be serologic and correlate great with the spinal fluid, that would be even better. But at least as to date, I have not seen that be a thing that is reproducible. Again, other typical biomarkers we've seen with central nervous system disease, things like serum neurofilament light chain. That one, there just isn't great normative data to benchmark patients against, so we don't routinely use it in our practice. But there could be something that, again, if we keep studying it and show strong correlation, that could be an indicator of relapse. If a patient, say, is having relapse symptoms and you checked a serum neurofilament light chain and it was significantly higher, could that be an indicator that they're going through an attack? There is potentially going to be a role for some of these. They're just not ready yet to be used at the bedside in our practices.
And then, as we're still talking about monitoring patients, and we've alluded to this a little bit before already, but as you're monitoring your patients, what's going to trigger you to take action as you're seeing some type of relapse or some type of different disease activity?
It's the single most important question you've probably asked so far. This really, really is important. Knowing that optic neuritis and transverse myelitis are by far and away the most common clinical presentations, I think using that to our advantage and educating as many people as we can that has touch points with our patients. So the infusion nurses, if they're going for infusion-based therapy to help with their disease, making sure they know what optic neuritis and transverse myelitis symptoms sound like when a patient maybe starts to have complaints of that. All of our nurses that triage phone calls and MAs that triage phone calls on our patients in our practices, knowing them ourselves as the healthcare providers, and that, again, close to 95, maybe even a little higher percent, 95+% of patients have those two presentations. And so if we know what those signs and symptoms look and sound like from the patient's perspective, then we would know what to look for and capture most of the time when to be worried with our patients, both at the time of diagnosis to get the diagnosis right, but then also monitoring people over time, since that's going to still be, even though I've taught that there's 6, those 2 by far and away are the most common to really understand and be on the lookout for.
Moving beyond monitoring patients a little bit back into that disease activity, we've talked about mild, moderate, and severe attacks, but are there other signs or symptoms that may be unrecognized that are telling you there's disease activity happening?
There absolutely is. And it's a really great follow-up question to what are the triggers that would make us be better about monitoring this for disease activity over time. So if we understand optic neuritis and transverse myelitis, that's going to capture 95+% of the types of problems our patients are going to have, but that still leaves unanswered those other 4 to 5% of clinical symptoms, and those, again, 4 clinical characteristic syndromes that we really haven't discussed in detail. But those minority clinical characteristic syndromes are where disease sometimes can start to slip by us. And so just knowing what they are. So maybe perhaps the strangest of them, again, we talked a little bit about, is persistent hiccups and nausea and vomiting, and having that be actual clinical syndrome, having it be aeropostrema syndrome. That one is the third, distant third, but third most common way patients experience the disease. And it's pretty unique. And these patients don't often land in the neurology offices with those complaints. They're seeing their primary care doctor. They're being told maybe it's their diet. They're thinking there's a GI problem, and they might even get referred to an entirely incorrect specialty for that if it ends up being aeropostrema syndrome. So knowing those ones, and there's so many examples that we've had in our practice where patients, that's exactly what's happened to them. They bounced around from ER to ER, saw a GI doctor. It got better over a handful of weeks because it had a crescendo, decrescendo to it, and it was actually part of either the beginning of their NMOSD or part of the disease process even after diagnosis. That's one. Those other three absolutely can be the case. Symptomatic brainstem syndrome is something that can happen with NMOSD. So kind of weird bouts of double vision or difficulty swallowing, kind of some of those typical, what we end up localizing to brainstem symptoms can happen with patients. And if it's a smaller brainstem attack, then patients again might just have mild and annoying symptoms or moderately effective annoying symptoms, but not enough to drive them to become blind or become paralyzed. We can see with the more common problems of optic neuritis and transverse myelitis. So those are kind of a few examples of kind of outside the norm that patients' complaints that they can have, but that we absolutely need to know can happen with the disease, and raise our index of suspicion for more testing and getting MRIs done and trying to help patients with if they're having those maybe smaller and not quite as severe, but still very clinically relevant attacks.
And I'm just curious because you've piqued my interest now in talking about these patients, especially who have the hiccups and nausea and vomiting. And you're saying, oftentimes there's bounced around with the general practitioner or to a GI doctor. How long do you think it's taking them to find their way to a neurologist?
So it's a great question. So if that's their presenting symptom, they often don't find their way to a neurologist quickly. And so hopefully, episodes like this kind of raise awareness to keep our general practitioner colleagues aware of this condition, albeit rare, but still a way in which these patients can start to experience their disease, educating our GI colleagues, educating the ER doctors. They're often the first touch point with these patients. If you have incredibly persistent and annoying hiccups and you go to the ER, that should be concerning for if you're a young, otherwise healthy person, often women, because 90% of this disease is being experienced by women, then that should be something I think an ER doc could start to familiarize themselves with and have a kind of a heightened sense of awareness to it, given how, even though rare disease is, how unique it is to this condition.
And when you're seeing some of these patients with these not as common symptoms come in, when you're seeing them come to you, especially with the sensory symptoms, what's your first line of action? What are you going to do first when they come to see you?
So if the person's already diagnosed and they contact us with new complaints, say sensory complaints, we often err on the side of assuming it's an acute relapse and starting the process to treat that. We'll look for mimickers, things that might trigger a pseudo relapse picture, things like if the person is experiencing urinary tract infection, or if they have a concurrent upper respiratory tract infection and have cold-like symptoms, that actually can cause a recrudescence, kind of a pseudo relapse picture where they can start to re-experience some symptoms, and then acute relapse treatment is not needed. So we have kind of built into our algorithm of questions that our nurses learn to triage patients, and that us as the healthcare providers that are making the medical decision on whether or not to treat for relapse know that can happen. And we've got a pretty clear familiarity with that because that's pretty common also with MS patients, that if they're experiencing a relapse, it has to be in the absence of a provoking factor like an infection, something that's raised their core body temperature. If they've walked outside on a hot day and their vision starts to get blurry and things like that, it very well could be an overheating phenomenon that can happen with both conditions, actually, MS and NMOSD.
And I think we'll wrap up this episode with just one last question. And then, of course, we have one more. The focus for NMOSD is typically zero attacks, but it's not necessarily zero activity. Can you explain why there's that difference?
I understand the premise of the question, and I think we're looking at the same situation, just maybe through a different lens. MS, absolutely. No evidence of disease activity is the standard benchmark approach on how we're trying to help our patients. So no attacks, no disease activity that we can see on MRI. And the reason we use MRI a little more frequently with MS patients is that subclinical disease is just frankly more common. In NMOSD, it can happen, and I have seen it, but it's such a rare occurrence. That's why in our practice, we don't utilize MRI consistently in every single patient scenario as kind of a treatment response biomarker, let's say, to the same degree that we do with MS patients. But it's still our focus. We want to see zero attacks and zero disease activity on MRI. Thankfully, though, with NMOSD, there's a much stronger connection between those two, meaning that if you prevent clinical attacks, often with the help of disease-modifying therapy, and thankfully, again, we have 3 FDA-approved treatments now for seropositive NMOSD. If somebody's responding to that treatment and we're preventing clinical attacks, there's a pretty strong marriage that we're also preventing subclinical disease that we would see on MRI. Again, we have a few exceptions in our practice on patients that have had subclinical breakthrough disease, and so we do utilize MRI monitoring in them, but it's more the exception, not the rule.
Dr. Robertson, thank you so much for your time today in this second episode. And as you know, we have one more episode. I'm looking forward to speaking with you then on our discussion about NMOSD, and we'll talk to you soon. Thank you.
It was great. Thanks, Wendy.
Thank you to Dr. Derek Robertson for sharing his knowledge with our listeners in this episode of Neurology Disease Deep Dive. And thanks to you, our listeners. Be sure to visit practicalneurology.com for more podcasts in the neurology field. Neurology Disease Deep Dive is brought to you by the editors of Practical Neurology and sponsored by Horizon Therapeutics.